Good evening, everyone. My name is Jane Robinson, and I'm Pro-Vice Chancellor for Engagement and Place here at Newcastle University, and absolutely delighted to welcome you all on this beautiful summer's evening, and very impressed that you have chosen to join us at the Newcastle Debates event here at the Frederick Douglass Centre. Can I just check, can everybody hear okay? Wonderful stuff. Okay, so tonight is one of our Newcastle Debates events. This is actually the 6th event in the series that we run, looking at policy issues that we hope are relevant to the wider public. Before we kick off, a couple of housekeeping points. Please, can we ask if you could turn your phones to silent, please? That would be very, very helpful. But please do feel free to use social media, and if you are tweeting, please use the hashtag Newcastle Debates. We're not expecting a fire alarm, so if the alarm does sound, please follow the instructions of our events stewards and make your way out of the building into the square. So tonight we will be discussing the future of the NHS. The NHS reaches its 75th birthday this year, but many may say, is it time to celebrate when recent events have revealed a system and arguably staff at a breaking point? The public still shows significant support for a National Health Service, with 94% of people agreeing that healthcare should be free at the point of delivery, and 84% that care should be available to everyone. But at the same time, satisfaction with individual NHS services has fallen to the lowest levels since records began with the British Social Attitude Survey in 1983. So the question arises, how can we balance increasing costs with delivering a quality service? And what can we do to support NHS staff? We've already received some interesting questions, which have been submitted in advance by tonight's audience, and I will be putting those to our fantastic panel shortly. But if you would like to join in the debate, there will be time for further questions at the end. So we will carve out some time for that, and there'll be a roving mic that'll be coming round. So as we go through, if you have questions, do prepare them. We'll take as many as we can. So as I say, we're really pleased to be joined by a great panel this evening across a number of different experiences in relation to the NHS and healthcare more widely. So I'm going to run through now and just ask them to briefly introduce themselves. So first of all, Professor Clare Bambra.
Oh, hi. Good evening, everyone, and thanks so much for giving me the honour of being here and getting to talk to you. I'm Clare Bambra. I'm Professor of Public Health at Newcastle University. My research has focused on health inequalities, particularly on examining the North-South health divide and inequalities within the North East.
Thank you, Claire. And Guy Pilkington.
Hello, good evening, everybody. I'm Dr. Guy Pilkington, a GP by trade, and I'm still practicing a little, not a lot, at Crudders Park Surgery up the road from here. That's where my clinical experience comes from. I have a couple of other hats that are relevant today. I continue to chair something called the Prevention Board for the North East, which is attempting to improve our investment and efforts around preventing ill health. And I also work with a charity called Ways to Wellness, which is based here in Newcastle and has been one of the innovators in the early days of the idea of social prescribing.
Thanks very much, Guy. And Dr. Benjamin Adejabami.
Hi, everyone. I'm Benjamin Ajibade. I'm an assistant professor of mental health from Cumbria University. My research interest is around equality, diversity, and inclusiveness, and my particular interest in this session tonight because I mean the higher education is to think about what can we do more in the higher education sector in producing the healthcare staff that are actually running that NHS. So that's where my interest is.
Thank you. And James Duncan.
Evening, everyone. Does this work? Excellent. I'm James Duncan, and I'm Chief Executive at Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust. That's a very, very long name. Like that? Where did I have it before? I really should have had one of these lapel ones, shouldn't I? Anyway, yes, so I'm James Duncan, Chief Executive of Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust, very long name. I'm an NHS lifer, so I've worked in the NHS for 31 years, 23 of those as a director, latterly as Chief Executive. My area of expertise, where I've worked, is in mental health, disability services, and I have remained in the North East all that time as well. So I'm delighted to be here as part of this debate.
So, ladies and gentlemen, our panel who bring, I think, a wealth of experience and expertise to this subject. But this is very much about hearing and responding to the questions that you have raised. Before we start, I think a quick show of hands. So, can you put your hand up if you have used the NHS services in the past year? So, pretty much everybody in the room. Okay. Can you raise your hand if your experience was a positive one? Okay. So for this audience, a pretty positive experience. Quick other check. Who actually works for the NHS? Okay. Quite a few. Okay. And was your experience a positive one? That wasn't scripted. Okay, so I think what we'll do is we'll work through some of the questions that that the audience have submitted in advance that are ranged from a number of different things, and I think we're going to start with quite a challenging one, which really goes to the heart of this question around the future of the NHS. And the question was submitted: how can a publicly funded NHS be sustained in the future unless there are significantly more resources invested in the care sector? So I think I'm going to initially come to Clare for her response to that.
Okay, thanks. I admire the thinking behind the question, which I've chosen to interpret as what about kind of everything other than the NHS, obviously including the care system. But when I was first asked to be on the panel, I thought, big question, future of the NHS. What is the future of the NHS? Where does it lie? And I think this is where it links to the question, is that the future of the NHS in many ways is nothing to do with the NHS. It's very much to do with other demographic trends, political trends, but also to do with big inequalities that we experience, particularly here in the North East. And yes, the care sector also has a role, as do other community services, and of course, as you'd expect me to say, public health. So when we talk about the future of the NHS, why is it outside the NHS? It's outside, as the question alludes to, in terms of the other services that are needed in order to sustain and support a healthy ageing population. So yes, I would agree, we need to support the care system more than we have historically. We've lacked that historical settlement for social care that mirrors the offer for NHS care. And I'm sure colleagues can talk a little bit more about that from a kind of service perspective. The other way that the future comes outside the NHS, of course, is in terms of the longer term drivers. We can see that in terms of population change, an ageing population, but also in terms of some of the issues around, for example, immigration, with reductions in numbers of medics and other healthcare professionals coming into the UK from Europe. So I think the third element is around prevention, which I know Guy will be able to talk about as well. But when we're thinking about what's driving some of the extra demands on the NHS, It's having a burden of ill health while people are still of a working age. And so if we can push that back into later life, we might be able to reduce the kind of strains that we're seeing within the NHS. But I'll let other colleagues come in now as well.
Thanks, Claire. I think, you know, that notion that the future of the NHS is not really to do with the NHS is really interesting. And listen to Matthew Taylor, the Chief Exec of the NHS Confederation, recently talking about, you know, health policy is not the same as NHS policy. So just interested. I think, James, you describe yourself as an NHS lifer. What's your take on this question?
It's really interesting, isn't it? And you gave the statistics at the outset around the public support for the NHS. And everyone talks about public support for the NHS, and it is just for the NHS. There is very little talked about politically, really, around the wider care sector. What do we even mean by the wider care sector? Many people might think we talk about local authority care. What about voluntary services? What about charitable services? So I think we've got to have a very, very different discussion because the NHS can't survive as an island. And what we've effectively got, the NHS has become a crisis service. So what we largely deal with is when everything's gone wrong. And that's what we do. So there's a whole debate as to how do we take as much responsibility for our own health in our lives. How do we, with our communities that we're living in, take responsibility collectively? And how do we break down those divides that we've got across all the different elements of people who are supporting us and providing care? Because it's really, really very, very disjointed at the moment. And we need to take a very different look at that. And part of that might be to widen our thinking and maybe fall out of love a bit with the NHS and then maybe think wider about the wider health system of which we ourselves are a fundamental part.
Thanks, James. So I suppose that, you know, sense of a wider health system and how we sort of don't get to the point of crisis. I mean, Guy, you spent much of your career at that kind of front line in primary care, and now obviously taking on a role thinking about prevention. What would your perspective be?
When we were having coffee and tea out there earlier, we were slightly anxious that as a panel we would agree about everything. And I do kind of absolutely agree with what I've heard so far, both from Claire and James. I think the short answer is the NHS won't find it easy to continue to deliver universal care, free at the point of need, funded by taxation, etc., unless the care sector is fostered and nurtured significantly more than it has been in the recent past. Because if we don't have anybody from an acute trust here, but they will tell you that they know that their efficiency and effectiveness as organisations at hospital level is completely dependent on being able to get people longer term care in order to get people home again, for example. And in general practice, we know, much as Claire says, that what we deal with on a daily basis is absolutely rooted in how society is structured on our doorstep. And here in the Northeast, we aren't in the fortunate position of being the wealthiest part of the country or having the greatest or equitable share of resource based on need. And so as a result, we feel that lack of investment in care, the care sector itself very much. And we see the impacts that that has on people. I remember a long time ago, when you were a chief exec of a local authority, Barnet produced the Graph of Doom, which many of you will be aware of and know. And that was that the way local authorities funding was being cut from about 2010, 11, was leading to a stage where they only had resource to be able to provide adult and children's social care, and nothing else could possibly be provided. Well, that's kind of very much come to fruition in a way. And I remember asking somebody at Newcastle Council, I said, why is that north-south divide so stark? Why is this formula leading to the fact that there's nothing left here in the northeast compared to where I was born and grew up, which happens to be Richmond, Surrey? I just cannot believe that Richmond, Surrey has had to slash and burn in the way that local authorities up here have. And they said it was to do with the need of the population here, who have, for whatever reason, less resources with which to look after their families and so on, because of that wealth-poverty divide that we see across the country. And I think so much of what we struggle with as national organisations is Clare's areas of expertise, just how inequitable society is structured in the UK.
And Benjamin, coming to you, I think that question of, apart from spending more money on the NHS, what more could we do to improve health and care services?
Yeah, thank you. Apart from spending money, I think from education perspective, looking at the higher education provision, I think there is more to be done in that area, because when we look at the courses that we run in the universities, because all these have very big impacts on how the NHS is run and actually how the NHS can survive longer term. So I think there's need to improve on all these, improve on technology. Then looking at research area, I think we need to look in depth into researches in that area of NHS sustainability, because there is not much research in that area. We do research about disease conditions and so many other things, but how can we actually survive as NHS? Although the panel members talking about the problem of NHS are outside NHS, but my perspective might be a little bit different, because when we look at leadership in the NHS, there is a lot to talk about. I've worked in the private sector, I've worked in the NHS, I'm in the higher institution, and there are a lot of things that could change, because, governments enact all these policies and things, but how are these policies actually translated in the NHS by the NHS leaders? Who are those leaders in the NHS? Are they actually proficient enough to do and act and perform the role that they're being given? So there's so many questions to be asked. Unfortunately, as well, when we look at the political agenda in the UK, there is a lot of issues with the political agenda in the UK. It's not really so much about how much money we pump into the NHS. It's about how we manage the little fund that we have in the NHS. I'll use an example. I was a manager of a very big care home. I've been in the Northeast for almost 20 years. And when I started the job, I got into the treatment room. And the medication that has to be wasted, that are not expired, when I calculated it, is more than £1 million. They've been there for years. Nobody cared about it. So as a new manager, I have to go in. I don't like all those clusters. I need to get rid of them, because no one else can use those medications. So that's £1 million worth of medication. If we send it to developing countries, it will save millions of lives, not thousands of lives. So I think NHS, sorry for taking it a little bit in a different dimension, is, if I can use the word waste, we waste a lot of resources in the NHS. And I think we need to do more in managing the resources that we have in the NHS. I forgot the government that asked for 20 million to be saved by all the NHS a few years ago. And we're able to save that 20 million per NHS in the UK. So where did that money come from? How did we get it? So there is more we can do rather than just pumping money into the NHS. Thank you.
So it's not a question of money, it's around better management and wasting less. Claire, do you want to come in on the back of that?
Yeah, I certainly do, yeah. We are getting a debate now. I won't go into the details because obviously I'm not, jobbing in the NHS, but I wanted just to think about, when we think about, we always think investment in the NHS, and we think of that as public investment. But if we think outside that, we think investment in health and social care as a whole country. So many of us in here, many in the audience, will probably be paying for, or will likely have to pay for their own social care at the moment, right? That is part of our resource collectively as a country, whether we pay it individually for our mums and dads or for ourselves, or whether we pay it collectively through the NHS or a more kind of similar model for social care. As a percentage of GDP, we are all still spending it. When we go and we choose to use private health insurance, that's a payment. That's part of a healthcare resource as a whole country. So if it's about investing more in the NHS, there are ways that we can get that. It doesn't have to just be through tax take. There is resource in there. People are opting out, or people are forced to opt out because there is no public offer in the case of social care. So whether we would have to spend huge amounts more in order to provide an actual universal offer, I think is debatable, because I can see lots of nods in the audience, and many of us here know about people, parents, etc., who are having to pay, even with children's social care needs in some cases because of the cuts that Guy mentioned. So I think we need to think of it in that more macroeconomic context of, as a country, individuals, families, the state, we're paying this. What if that was all packaged within the state? Now, I realise that does get obviously into political debates about taxation and about collective provision, but it seems to me that particularly on the social care question, part of the reason we're in this crisis nationally, how it's impacting the health service, particularly through COVID, and how it influences individual families. It shouldn't be a catastrophic financial event for your family that your elderly mum's got dementia. But for many people, that is a reality. And we can solve that. You're paying, but why shouldn't we collectively pay and provide that reassurance to all families, to all parents, etc., in this situation? So there is resource. It's just where it is and where we're, in a sense, being forced to put it at the moment.
Can I add one other thing that I think I completely agree with Bambra next to me here. And that is, I think, the other thing that we absolutely need to do is we need to value the care workforce much more than we currently do. It is very much a Cinderella service, and people are on minimum wage and so on. And the reason I particularly wanted to make that point was I was still working pretty much full time as a GP through the pandemic, and I had a particular care home that I'd been visiting for about 20 odd years, and I continued to visit through the pandemic at a time in the worst bit of the pandemic when they were care homes and the residents were hung out to dry. And not many GPs were going into care homes at that point, and I felt it was completely wrong that we weren't doing so, because we were asking minimum wage care workers to continue to go into those care homes. So I did continue to go in, and it was really, really difficult for those care workers. And, they gave everything for their residents, and they saw some of them die in not very pleasant circumstances at a time when we had no treatments and so on. So I think it is, it's important to say that they are undervalued, underpaid, and unless we recognise that, it's going to be difficult to build the care workforce that we need for our new sustainable, all-inclusive system.
Can I come back to that sort of question of staffing, and if we think about that sort of whole system across health and social care, it is a huge challenge to recruit and train the people who are needed for that. James, can I come to you and sort of ask the question around the shortage of staff? Is that something that you're facing in your organisation and that you see? And arguably, has there been an over-reliance on recruiting doctors and nurses from overseas? And are there ways in which we can encourage people to come into the profession?
Probably, can you hear us now? It's working. It doesn't seem to be, does it? On? No?
Well, I think we've got another mic on its way.
Does that work?
Silence, Matt.
Didn't do it deliberately, James. Probably.
What about that?
Yay!
Fingers crossed. I've forgotten the question now. I could probably talk about this forever. The whole issue of staffing, and it sort of links to the conversation that we've just had there. Because we keep saying that we've got masses of vacancies across the NHS, and yes we have, and across social care, and yes we have. And across the NHS, the figure nationally is somewhere around 150,000, but we've also got more clinicians, more doctors, more nurses working than we've ever had before. And this is the conundrum, but it's a graph that keeps on going upwards. And it probably will keep on just going upwards and upwards while we keep trying to do the same things. And I think this is the fundamental question for me, is how do we think very differently about what we mean by health and what we mean by healthcare. So I've said I'm an NHS lifer, and I do love the NHS. But when we talk about the NHS, and when people say they love the NHS, they're generally talking about hospitals. And that's what we talk about, hospitals, and the local hospital in particular, and that's where that's what we feel. But a lot of our money is spent in the NHS, is spent in hospitals. And we've got to change the curve on that. We talk all the time about wanting to do more on prevention, but we really struggle to do that because all of the time we're working on that end of expenditure, we're working on the level of crisis. So I'll get to the point about recruitment. So actually, we do recruit well, and I can say in our organisation, we've got more people than we've ever had working in our organisation. I can also say that it feels more stretched than it's ever felt in our organisation. So those two things are happening at the same time. In terms of recruitment, I think we've still got to recognise that the NHS is a good place to work, and it's a particularly good place to work if you live in this region. In terms of the remuneration, in terms of the pension, in terms of the affordability of housing, all the rest of it, there are some really, really positive aspects to working in the NHS in this region. So we've got to sell that, and we've got to sell it well. And we've got to not always talk ourselves down. I think that's really important. We've got to look to recruit young. We talk about inequalities, and there's a great potential for a huge win-win here for us to actively go out and recruit in the most deprived estates across our area and bring people in young and train them and give them all the resources and give them a career that has got so many opportunities and so many opportunities to create a stable, successful life for the next generation. So there are things we can do that are both going to recruit for the future, but also address some of the issues of inequality. In terms of our approach to training, it would be great to have a long-term plan. It would be great for us to really invest in training. It would be great for us to see that if we are going to have doctors and nurses in the future, then we need to start training them now to get a return in 5, 6, 7, 10 years' time. And we've done all sorts of things like take away bursaries and make it harder to do training, and people coming out of their training with huge debt. And maybe those people who've gone through all of that say, well, what's my commitment to the NHS? Actually, I might go and live in Australia and get paid there. So, what are we doing around really creating that bond and that buy-in to the NHS, and how are we creating that workforce of the future? There's a lot we can do. There's a lot we are doing. But let's be a bit more optimistic about it as well.
Because there has been a long-promised workforce plan for the NHS that, I think there was talk of that being launched, I think, any day now, but...
So there has been talk of that being launched any day now, for many days now. It's an endless, it is going to be, well, it was an endless, it's going to be launched any day now until, I think it was a week ago, wasn't it, that Patrick Bartley said, Stephen Bartley even, Patrick Bartley didn't say it, he was probably doing something entirely different. Steve Bartley said that it's going to be, I don't think it was delayed indefinitely, but it certainly wasn't, it's going to be coming out tomorrow. And why? Well, almost certainly because it's got quite a substantial pound sign next to it. That's the reality.
Can I sort of just push on this a little bit more? So just sort of, we've mentioned Steve Bartlett. What about the Labour Party? And we've got a question here. The Labour Party appears to be committed to using spare capacity in the independent sector to bring down waiting lists, which we know is a big political issue at the moment. Interested in the panel's view on how using NHS-trained doctors and nurses in the independent sector affects the provision of services in the NHS. Probably want to start with you again, James, I think, and then...
So at the moment, I think it's the right thing to do. We have a lack of capacity at the moment. There are issues about using NHS-trained staff in the private sector. One is the cost, so the burden of that falls on the public sector, and the benefits reside when they're working in the private sector with the private sector. And there's also an issue of capacity, because if we have a scarce resource, then that resource can only be in one place at one time. But at the moment, we have got a lack of capacity to do the things that we want to do today. So I don't really have an issue with using the private sector to do that. I don't really have an issue with who does the work necessarily. But if there isn't a long-term plan, if there isn't a plan about how we get the capacity right for the long term, or what our model for the NHS is for the long term, then that's likely to be destructive over the long term. And it feels like we're lurching a bit, sort of lurching from crisis to crisis, instead of actually, what is the plan? What are we aiming for, and what are we going to deliver over the next 10 years, over at least the next 10 years? So we've just, over the last 10, 15 years, we've lost a real opportunity to invest in the capacity of the NHS in terms of its infrastructure, in terms of digital technology. Money was as cheap as it's ever been. And during that time, over the last 10 years, we've had the smallest programme of investment that we've ever seen in infrastructure and digital technology. So we've missed a real opportunity. We've got to think about how do we get that opportunity back, because all the time, if you've got, we've got to use capacity where it is. At the moment, we are constrained in the NHS, and there is capacity available in the private sector. So we're just going to have to use it in the short term, but that's not a long-term answer. We need a plan.
Did you want to come in on that question?
Yeah, I agree with you about it's not a long-term solution. I'm not even convinced it's a short-term solution. What is the size of the private healthcare sector in this country? I think it counts from maybe 10%. Right, so 10% of 7 million waiting list, 700,000. Okay, that's a lot of people, but there's still 6.3 million that won't be impacted. who works in the independent private sector? Yes, they'll have some of their own staff, which, as the questioner points out, we've paid for and trained, but they'll also be having our consultants working for them on a Friday afternoon. Longer term, it is better to pool our resources within the NHS than to carve off into a private sector. And again, who will get that private sector? Who will be exercising their choice? So the North East, I think, has one private hospital in Newcastle. Is that a choice that you're going to be able to take, even if you're offered it, if you're out in rural Durham and it takes 3 or 4 buses to get to that private hospital? Or is it an easier choice if you've got a car or you live in Gosforth or Desmond? We probably don't have time to go into all the ins and outs, but I did think it was a statement that may be problematic from the Labour Party, frankly, even in the short term, because the scale is not there. We don't have a spare NHS in the private sector just waiting and get 7 million through the doors. It might, I appreciate, cause a bit of a respite for a short amount, but it's not I don't think it's even a short-term solution, to be honest.
And Benjamin, can I come to you as an education provider, who's looking at training and providing that workforce of the future? And in your earlier comments, you talked about, that working with the private sector. What's your take on the question of the relationship between the NHS and the private sector?
Thank you for the question. Unfortunately, where I'll start the answer from is that, do we actually have those staff in the private sector? Because as Clare said, it's not a short-term measure at all. There is no measure there. I think the way we look at our workforce plan, the way we look forward into the future needs to be revisited, because we're not planning ahead enough. Because when we look at this little staff that we have in the NHS, in the private sector, and we want to be tapping from those staff for the NHS, then there will be shortage in that area more as well. So we need to think around that area. But when we look at staff, because all this boil down to the recruitment of staff, how do we retain our staff in the NHS? Although we have the training providers, we open the doors, we have students every time coming onto the course, like James said before, there is bursary for nurses when they go on training. They remove those bursaries. So now they go complete the course with a very, very high burden of money to pay. Some people will pay it even for 20 years of their working life. Out of how many years are they going to work? There are so many areas. Then, although we have all this input of nurses, staff or students coming into the higher institution, how many are leaving the professions as well? Because what are we doing to retain those that have experience, very good expertise? How are we retaining them in the profession? So what we are actually doing is we bringing in more staff into the NHS while we are losing, at least I think, a little bit more than what we are bringing in. When we look at all these, the age limit, people are growing very older now. So it means that there is like a burden on the NHS more and more year by year. So which means we need more staff. But we're losing all those staff that we are actually producing because we can't retain them. We can't maybe encourage them with, I don't know, whatever we can. Because if we actually research and ask these people, okay, what can we do to let you stay on this job maybe in the next 5 years rather than leaving? I know many nurses that resigned their post and went to Tesco and asked her to stack the shelves because they are on a ridiculous amount of salary in the NHS, in the private sector. Because when they stack a shelf with very, very little responsibility, they get £12 an hour. They get more than that. but working in the healthcare sector, do they actually get as much? So there are so many factors that affect our healthcare system in the UK, and I think we need a better workforce plan.
So that kind of issue of not just recruiting but retaining retaining staff, and I think kind of coming back to your earlier point, Guy, about sort of making sure that not just in the NHS but the wider system, people feel valued and actually not just feel valued but are able to maintain those roles. What's your experience from a primary care perspective?
I think in some respects, primary care has suffered from a lack of investment compared to what James was talking about earlier, this incessant investment in hospitals. So from when I started in general practice to now, I think the growth in the general practice primary care budget has been a small portion of the NHS growth as a whole. And we know that when I started, I think we had possibly 4 or 5 dermatologists at the RVI, and I think we probably have about 20 now, and there's been a massive growth in hospital specialisms and the hospital specialist workforce. The problem for general practice has been that the investment has led to a failure to continue to invest in small list sizes for GPs. When I started in 1989, I think it was, the whole trajectory was that investment was leading to smaller list sizes per whole-time equivalent GP.
The building will be closing shortly. All students is about to leave.
I think it's fair to say we can stay in the building a little bit longer.
Can we? And that, I think, has been a shame. But we are also quite fortunate in that the size of our organisations means that it is easier to create teams that feel cohesive. And when done successfully, people tend to stay for a long time in general practice, whether it's clinical or non-clinical staff. But things have never been harder for the primary care workforce than now. Although it was lovely to see how many people felt that the care that they had got this year was of satisfactory quality, I think if you ask the audience how many people have struggled to get an appointment at GP practice, I think there would be a lot of hands showing as well. And the strain on general practice is absolutely monumental at the minute. So, as a result, we're seeing GPs, who I know as a profession quite well, leaving at the earliest opportunity, retiring as soon as they feel that their pension is manageable. Many of the youngsters are choosing to go abroad for a couple of years, and so on. So that workforce retention element is an acute problem now in general practice, I'm afraid.
So shall we ask that question? So, show of hands if you've struggled to get a GP's appointment. Yeah, most of the audience, and I think sort of anecdotally that would be quite typical. We've talked a little bit about that sort of sense, and we focus a lot on hospitals and the acute trust. James, in terms of mental health, historically, I think there's been a sort of sense that mental health services have been a sort of Cinderella in terms of the NHS. I think, but at the same time, there was a growing recognition of mental health issues around the pandemic. What's your sort of view of where those services are now and the sort of potential future?
Thanks. So the services are really stretched now, and we've seen a number of things happen in the pandemic. And we are seeing, I guess, demand for our services grow significantly. It's very difficult to understand what's behind that. Is it because people are more mentally unwell? Is it because the other services, the other supports that they relied on are no longer in existence? Is it because our attitudes have changed? And the honest answer to that, it's all of those and more. But we are dealing with a huge level of demand in relation to capacity in mental health services. But I'd also say that over the years, and much of this has been very well-meaning, but over the years, we've created a really complicated system in mental health with lots and lots of different specialist teams. And that can make it very difficult for people to navigate around the system. It can make it very difficult for people to get the support when they need it. Now, Guy talked about the situation in primary care, and the situation in primary care from a workforce perspective is really, really difficult. But really, for me, the answer is how do we work very differently and break down those boundaries between services like ours and primary care and the voluntary sector and others, and how do we genuinely talk properly about early intervention, supporting people through their life journey. Mental illness is a lifelong condition, but we treat it in a very episodic way. So people will get some treatment when they have a particular need, but then that treatment will be withdrawn again, and then the cycle will start again. And we know that, but we keep on doing it. So we need to think very, very differently about how we support people through their life course. And we have things that are just getting overwhelmed. So our services for young people who have needs, developmental needs, perhaps around autism or ADHD, and they're waiting for months and months and even years to get an assessment. We know that. And what happens at the end of the assessment is there's not a lot that goes beyond that. So what we really need to be thinking is, as those needs arise, what support do people need? What support family needs? How do we get that right first time, rather than people waiting to get a diagnosis? And often that's driven by the education sector, and often it's driven by people's and parents' desire to get the right support for their children in school. Well, that should be something that's just right. So there's a lot of things that are leading people into, I guess, medicalisation, into the mental health sector, and we need to think very, very differently around that, and then wrap around those people who really have got significant mental health needs.
And just sort of picking up that point, there was obviously a lot of coverage in the media at the end of last week about Metropolitan Police's stated intention to no longer respond to calls which involve issues of mental health unless there was an immediate risk to life. Is there a sense that is a sort of issue in this region? And what's your take of I suppose from perhaps starting with James and some of the other panels about, that sense of, is this a problem that is simply getting moved around different parts of the public sector? But James, you're, as someone who's worked in mental health, your response to the Met's announcement?
So I think the Met's announcement is just moving the problem from one part of the public sector to the other. So I think that is the reality. We have a different relationship with Northumbria Police. I think we're in a better place. There's still discussions that are ongoing that we are having, but we are in a much better place in terms of our relationship. So we're not in that place as things stand.
Yeah. And others' view on this. I mean, Guy, from a primary care perspective, that sense of, is the sort of pressures in terms of sort of mental health issues something that is impacting significantly for GPs as well?
Absolutely. I mean, I have to declare an interest here in that, as far as I'm concerned, everything's mental health. So when I look at the police force, I think they're a mental health service. When I look at Changing Lives, who supply homeless accommodation in the city, I think that's a mental health service. I think our GP practice that I've worked in for 30 odd years is a mental health service. It just seems completely ubiquitous to me that unless we recognise the important influence that somebody's sense of control and their independence, if you like, and recognise that the pressures that that has on their mental health, whether it leads to behaviours that involve feeling anxious about what's happening to you and so on. Unless we recognise that for the importance that it is, I think our system will always struggle. And I agree with James, it's difficult to know why, but there has been a very significant increase in the number of presentations and contacts that people are looking for from the health service to do explicitly with their mental health, or are very much influenced by how confident they're feeling about their ability to look after themselves or their loved ones. So we can't address the challenges of the NHS for the future unless more is done to recognise how central people's mental well-being is as a generator of need and of an influence on the decisions that they take that have implications for us as part of the health service.
Thank you. Claire, your thoughts?
Yeah, well, I just wanted to think, like, why has this happened and why now? And there was a longer term trend in increases in, anxiety, depression, the more moderate end, rather than the more severe end of mental illness over the last decade or so, particularly in some neighbourhoods more than others, in more deprived populations. But then we see a big increase, a big shift in that surprise during the pandemic. So if we're looking at young people and reliance on CAMHS and services, there's a big spike in poorer mental health and well-being amongst 18 to 35-year-olds, particularly in the northeast, during 2020 through to the end of 2021. We basically ended up having a massive experiment, in a sense globally, but certainly thinking about in this country, in terms of telling children not to go to school, telling children they couldn't see their friends, telling young people, some universities, like not ours fortunately, but Manchester, for example, literally we can all remember seeing the students locked in their halls of residence. Kind of think there might have been a mental health consequence of that, as with some of the other consequences that we've seen. So there was a longer term trend, there's that. And then I think talking to my students, many of whom now we're getting the same issues in the university in terms of more students presenting with anxiety and depression and needing support from university. When you talk to them, there's all of that they've experienced. And then there's also existential threats, which when I look back to when I was their age, I wasn't worried about the climate. I wasn't worried about a European war with Russia. I was worried about, could I get to the gig at the Student Union tonight and could I afford the ticket? It's a very different world, I think, that our young people are entering and what they've experienced in this kind of formative early period of their lives. And on top of that, we didn't have access to many of the services during the acute phase of the pandemic for mental health, as well as for pretty much any other NHS service apart from any.
I think, like picking up on that point about, and I know this is an area that you've looked into, but that sense that actually the pandemic affected different people and different parts of the country in different ways, and I think kind of looking to sort of thinking about the opportunities of devolution. I mean, your perspective on that kind of sense of whether we're seeing those inequalities, those differences between different parts of the country increase, or, for all the talk of levelling up, are we seeing those gaps closing at all?
No, we're not. Unfortunately not. I think as colleagues have mentioned in relation to NHS services, and Guy outlined in terms of local government funding, the North East has suffered over the last decade or so in terms of disproportionate cuts. We've seen stalling life expectancy nationally, but we've seen reductions in life expectancy, particularly in the poorest parts of the country. So if we look at somewhere like County Durham, average life expectancy there has gone down by 6 months before the pandemic. So between 2015 and 2019, it will have reduced further again because of what's happened in the pandemic. And we can replicate that across certain parts of the North East. We've also, as a region, as many of you will know, we're the most deprived as a region out of England. And the impacts of the pandemic here from an economic perspective were higher, so more people were furloughed. Wages actually decreased slightly for those people that remained in work in the North East. We were put into lockdown restrictions for longer, all of which had an impact on local businesses and therefore local employment. So the pandemic was not good for the North East. It wasn't good for anyone. It wasn't good globally. But if we take a very kind of local perspective, it was a particularly negative experience for the North East. And I'm not seeing, the talk, sort of, I can remember maybe 2021, talk about building back better, about the levelling up, about recovery, post-COVID recovery, all this kind of stuff. And it just seems that we've then just lurched into another cost of living crisis, which again, Children North East have been producing figures recently showing, there's over 40% of children in Newcastle growing up in poverty, 40%, And there's a kind of sense at the moment that almost of either inertia, fatigue, or inevitability. But we also know, looking back historically, that wasn't inevitable. We have done things in the past that have reduced child poverty, that have reduced health inequalities, that have improved things for people in the North East. And I do hope that the devolution deal and how that comes through in the North East, properly resourced, I hope that is an opportunity for us to begin to build back better.
Okay, so picking up on that devolution point and the kind of, that balance, interested to just get the panel's views. The NHS, the clues in the title, the National Health Service, and we often hear about, targets that are set at a national level. So, and obviously heavy political involvement at the moment, a lot of focus on waiting lists as being a kind of key priority actually for both main parties. So question to all the panel members, and then we'll open it up to the floor after this one. Does the current political involvement in the NHS put too much emphasis on a national agenda when we should be focusing more locally? So Benjamin, can I start with you?
Yeah, thank you. So I think the national, sorry, what's the question again? The question.
So I think focusing on whether the current political involvement in a national health service puts too much emphasis nationally as opposed to locally.
Yeah, so I think the focus on the national agenda is like too much on the local policies, because the national agenda directs and focuses and dictate what we do at the local level, like it's been said in the panel. So how is this being managed at the local level needs to be thought about in a different way. And to do this, when we look at all what is distributed into the local level, there is no equity in that allocation, isn't it? Because if there's equity in allocation, look at the Northeast, for example. Northeast are a little bit more deprived compared to other areas in the country. So, and they have to manage with that local distribution that we have in the area. So this have impact on whatever is coming from the national level. So I think there's more to be done and look into at the national level. Thank you.
James, your take on this?
Yeah. So this is a difficult one. So I I do believe in localism, and I do believe that you're going to get a much better response if that's built around local needs, local infrastructure, local assets, local communities. So I think that's absolutely right. The issue then is, how do you agree basic national standards so it still is a national health service, and what does that look like? And the other great challenge is that because we spend 40% of our public spending on the NHS, it is a huge political football that keeps getting kicked around. And that's one of the real challenges here, is how do you get a genuine long-term plan and a genuine commitment of, these are the things that are like stick of rock, these are the things that you should expect from the National Health Service, but less day-to-day involvement and less day-to-day direction in terms of how that should be done. Because I think there's a whole host of innovation and there's a whole host of assets that we have in our own communities that we're not able to mobilise as much as we could, because we're responding to national requirements that are very, very, very rigid. And it's, you know, from a political point of view, I understand it, because they are, you know, it is the big issue, and it will be the big issue at the next election. And we can expect lots of new directives to come down over the next few months that will tell us how to get the NHS in the shape where that it can be portrayed as a success story. But that's not a long-term plan, it's not a long-term solution. So we do need to think about, how can we create a framework in which this can operate? And ideally, and this might be a bit naive, but ideally, if you get, you know, parties collectively agreeing to that, a framework that's a long-term settlement for the NHS, a long-term framework for it, but then enabling more localised devolution of how you implement that. I think that might be the perfect solution. Whether we can ever pull it off is a whole different question.
Oh, maybe that's the challenge for the next 75 years. Guy, I'm interested in your perspective as someone who chairs the prevention board for the integrated care system.
I haven't mentioning anything to do with prevention so far, so I was going to come in and talk about that. I mean, I remember after the 2012 Lansley reforms, I didn't endear myself to everybody in Keep Your NHS Public, because I do believe strongly in localism. And that's because, not because I want to see the National Health Service broken up, but because I think that the thing that the NHS has to do more of in the next 10, 20 years is understand how not to medicalise social problems. And I think we spend far too much time coming up with pills and potions when actually we could be investing much more wisely in building community level resources to engage people, to get them moving more, and improving their employment prospects, essentially that we create a more equal society across the country, than we invest in a new medical technology that will transform the health of our community. So because of that, I believe localism is very important. I think, to end on a more optimistic note for us here in the Northeast, and we know how badly done to we are as a region at a national level, but we have some fantastic people and resources in our communities on our doorstep. In the West End of Newcastle, it's a very vibrant, active, connected place for many, many people living in the West End. Often in very significant poverty. The child poverty is a scandal, and yet there is a human spirit there. And I think the NHS has to learn how actually, as we talk about anchor institutions, Newcastle Hospital, CNTW are anchor institutions. Well, I think, my surgery is an anchorette institution in a neighbourhood. And actually, we need to understand what that means, and we need to be working at community grassroots level far more than we do, because I think we have a role to play there. And I think that would help build a much healthier community, healthier society that would consequently make it easier to run a national health service.
Yes, of course, Clare.
Yeah, this issue of localism is one that often pops up, isn't it? And I think in principle, I would also be in favour of having more local decision-making, more involvement with communities, more democracy, dare I say, even within the NHS, with scrutiny there of what you guys do. But at the moment, because of the situation we're in this country, localism is a risk, I think, and we can see that. So you mentioned the Lansley reforms through the Health and Social Care Act 2011-12. What also happened there was that public health was removed from the NHS and put into local authorities. In principle, quite sensible. A lot of public health is about the community, it's about employment, health at work, etc. Why would the NHS be doing that if the NHS is a sickness service? I think that's the mantra, right, that underpinned it. However, it also was accompanied by huge cuts to those very same local authorities, including the public health budget. And it meant that, therefore, it's the local authority that was withdrawing services from you and from your community locally. When actually, really, it was the government through the way in which the allocation of funds was distributed. Similarly, within the NHS also experienced, reductions in spend as well, proportionate to what it needed. So there's a risk there, it's like a political risk to localism, if it isn't empowered enough. And then there's also, I remember when Andy Burnham first was talking about the devolution deal for Manchester around the hospitals, around NHS, and he said, I don't want a devolution of a deficit. So there's a risk that if you don't have it underpinned properly, that you can end up with a very even further justification for underfunding the North East would be my concern. You need, I think, to have devolution of a sufficient degree, like in Scotland or Wales, where you are kind of empowered and strong enough, in a sense, to stand up to Whitehall. Because at the moment, yes, we get a bad deal, but if I was living in the South East and I wanted to be a turncoat, I could easily say, well, we're paying for the North East, we're paying for Manchester. So what do we get back? So there are risks as a country that is so unequal to put localism in a light way at the moment. It doesn't mean it isn't in principle correct, but it would need to be done, I think, in a more radical and less tokenistic manner than it currently is.
Okay, so that's probably a good place for us to open up to the floor. I think we've had some really interesting perspectives from our panel members. Quite a few questions, I think, that are still hanging there around, certainly around kind of, the staffing of the NHS and social care, how we can deliver on devolution. So do we have any questions for our audience? Lady in the front.
Can you hear me? I've got a comment and a question. The first comment is I'm sitting here alive today because of the NHS. My GP, and this was prevention, my GP picked up while I did a mammogram, and the mammogram cancer was found. I was in the NHS system up here very quickly, surgery and all the other treatments, and I'm alive today because of the NHS and because of prevention and because my GP picked up earlier. So I just want to say thank you to the NHS for saving my life, and that the systems in place for prevention are excellent. So my experience of the NHS has been superb. So I just want to say that's my comment. My question, which again is about prevention, and it comes into an area which hasn't really been touched on. There's going to be a programme tonight, Panorama, about ultra-processed foods. And there's been a lot of debate in recent weeks and months and years that we as a country are sleepwalking into a pandemic, an epidemic of obesity, type 2 diabetes, high cholesterol, all these things. And there's also arguments about, it's people's choices and things like that. But if you are in a deprived area and you are a family of 4, you can go into a fast food establishment, let's not make a name, and you can feed that family for less than £10, but you could go to a nice department store and buy a teriyaki salmon salad, which will cost you £10. And so therefore there is a correlation, particularly with cost of living, that healthy, nutritious food is just disproportionately more expensive than ultra-processed food. And I'm wondering whether or not there needs to be a debate, and this is when I want to open it up, within the NHS and health policy and prevention to look at the food industry and to look at, given the huge burden that obesity and diabetes and high cholesterol and heart attacks and strokes and even cancers now, according to Panorama, because of ultra-processed foods, and whether or not there needs to be debate, maybe in a similar way to smoking, where we massively drop the numbers of smokers because of it, and whether or not the burden on the NHS because of poor nutrition needs to be addressed from a public health preventative aspect. Thank you.
Thank you. Thank you very much for sharing your experiences and that question. I think probably that my starting point is with Guy as the chair of the prevention board for the integrated care system. Is this food, nutrition, is this something that comes up on in your discussions?
Yeah, absolutely. I think it's a great question. Just quickly on the tobacco side of things. So our three main areas of priority in the prevention board for North East and North Cumbria are tobacco, alcohol and healthy weight. They all have some similarities, one of which is they have very, very powerful lobbies behind them. The industries that are responsible for the harms that are caused by exactly what you've said about run across alcohol and tobacco just as much. I just read an email that came through Fresh, our Northeast public health collective body that campaigns on tobacco, that suggests that it costs the Northeast £1 billion a year from the harms of tobacco, and that is the cost of cigarettes, the cost of healthcare treatment, and this is very much Clare's area, the economic impact of ill health caused by tobacco. Now, we all know about the tobacco industry and what that's done, but the food industry is doing the food and drinks industry is doing exactly the same. They are pushing hard to avoid the very obvious public health measures that would have huge impacts on the obesity epidemic, which is a great shame because, there's no possible way that treating obesity will ever achieve what we need it to do, which is to reduce the causes of obesity, if you like. I know people talk a lot about individual choice when it comes to your weight, but we didn't used to have this problem, and we have this problem on a gradient of affluence and deprivation. It is much more prevalent in areas of poverty. It's much more prevalent, therefore, in the Northeast and some other areas of the country. And I think it's important that we take away the burden of responsibility from the individual and accept that, again, it's a societal problem. And if you are living in areas of poverty, there are reasons why one of the things that you may end up doing, economic and otherwise, is eat unhealthily and perhaps eat too much. And those kind of things can only be dealt with by government policy. And I'm afraid it seems to be a lack of willingness to really engage with those kind of things at the moment.
I'm conscious of time, and I've got a number of hands that are going up. There's a gentleman here in the second row, and then gentleman in the blue shirt, and then the lady up here. What I'd suggest is if we can perhaps take the three questions, and then the panel respond to those.
Thanks very much. I just wondered whether the panel would acknowledge the foresight and wisdom of the Welsh Government in relation to young people and mental health, of actually awarding an unconditional income for young people leaving care of £1,600 a month. That's quite an initiative that they've actually taken, and I think actually informally Michael Marmot was actually on some of the subcommittees in Wales arguing for that kind of move. North of the border, the health provision as Scottish Government has given £2.3 million to the El Sistema, which is a music project, very similar to New Harmony that operates in the west end of Newcastle. Some of these things I've heard public criticism of, in commas, people getting something for nothing. That attitude still prevails in the North East.
Thank you. And we'll take the question from the gentleman here.
Thank you. I'm a member of Keep Our NHS Public North East, campaigning against the privatisation of our NHS, and we've been campaigning here in the North East for the past 12 years. So quite rightly, there's been much talk tonight about prevention of ill health and people taking their own responsibility for their health and the impact of the ageing population and the care sector and the need for better financial management of health services. But with respect, I feel that we might be ignoring the massive, great big elephant in the room. Does the panel agree that the main issue is mainly one of politics? It's politically driven. It reflects political ideals, a corrupt democracy, and a drive to a two-tier system underpinned by health insurance and indeed shareholders creaming off profits. Does the panel agree that a strategic, planned, what we're seeing is a strategic and planned, long-term, intentional rundown of a publicly provided and publicly funded healthcare system to enable a growth in the private sector?
Thank you for that question. And we'll just take the lady here. Thank you.
Hi, I'm just interested in the panel's views because both Guy and James mentioned about specialism. And when you look at people over the age of 65 who are the biggest users of healthcare services, if you look at people with dementia, the majority of those have 3 or more comorbid conditions. And currently navigating the health system is very difficult because of the level of specialism, with the specialisms working in silos and not talking to each other. And if we go back some years when we had fewer staff, we had less problems because you could actually go to a specialist who could prescribe what the person needed and meet their needs instead of having to go and see the diabetes consultant who can't change the psychiatrist's medication, who won't look at the respiratory consultant's medication.
Thank you. So 3 quite different questions that we're going to throw at our panel as we move towards the end of the debate. I think sort of firstly, this question, the example from the Welsh Government, but also north of the border, that opportunity, and you've referenced this, Clare, around sort of devolved administrations. Secondly, I suppose if I could paraphrase, is privatisation of the NHS inevitable, given the current political involvement? And thirdly, when we think about, the increasing, the situation with comorbidities, is an increasingly specialised approach to healthcare the right way to go? So let's start with the sort of the devolution and the Welsh Government question. If I can come to you, Clare, as an opener on that.
Yeah, absolutely. I presume you're referring to the Universal Basic Income pilot that they've got going at the moment for young care leavers. Yeah. So this is the Welsh Government's piloting, giving the £1,600 a month to 18-year-olds who are leaving the care system, so the most vulnerable children, and sort of, in a sense, helping to support them in that transition phase when they obviously don't have family in the same way as other children might have. And they're evaluating that. I think my colleague Kate Pickett from the University of York's leading the evaluation on that, so we can see the results when they come out. Just today in the news, there's talk about trying to crowd fundraise to do a universal basic income pilot in Jarrow as well, here in the North East. And there is, of course, evidence from experiments in Canada, Finland and other places suggesting that it is, particularly from a health perspective, particularly looking at mental health, particularly for the most vulnerable populations, as the questioner mentioned, that it could be beneficial. It's something that is discussed more in the mainstream in places like, let's say, Denmark, for example, where there's big policy discussions about that. I think it does get more broadly into this, what can happen when you do have strong devolved powers as well. So that's a pilot, but if we look at Scotland, then we can see that they've had a child poverty strategy since about 2015. That's recently included giving an extra £20 to every I think it's every family on universal credit in Scotland. Of course, all of the devolved authorities, including Northern Ireland, also mitigated against some of the austerity, for example, covering the bedroom tax, covering the council tax impacts and so on. So there are different things that can be done differently if there's enough power, I think.
Anyone else want to comment on that sort of devolution opportunity, an example from elsewhere or even internationally?
I mean, I think we have to wait for the evaluations, don't we? But I love the idea of universal basic income. I think it removes so much negative stigmatizing of the poor that I think is refreshing, and one would hope was able to demonstrate, and I guess has a good chance of being able to demonstrate loads of positive impacts. I think the care-leaving population are absolutely deserving of the best that our society can offer them, because you don't end up in care as a child unless you have been let down somewhere along the line very significantly. So, I love the idea, and I hope it proves that the evidence really strongly supports these kind of approaches. The slight peculiarity is it seems so out of kilter with the way everything else is structured in our society at the minute, and the way the politics seems to be being driven at the moment, that I'm hopeful that future governments and future policymakers are able to grow that idea in interesting ways.
Okay. Can I just chip on the politics? I've just remembered that it was, at one point, Richard Nixon, the Republican president, was toying with the idea of having some kind of universal basic income in America because they saw it as a way of simplifying tax. Because you would pay it to everyone, but then you just tax it back off richer people. So you're kind of giving and then you're taking. And we do have a form of universal basic income. It's called the state pension, so you can have it when you're older, right? So there is a principle that could be extended. But I agree with you. I mean, certainly where we are, and I think that feeds on to the second comment, is we'll probably have to acknowledge that we're nowhere in that space. Yeah. And it's great that Wales is kind of pioneering, creating, because even a sliver, right, can sometimes become quite a big crack.
Well, let's pick up. We've just got a few minutes left, so I'm going to throw it over to our panel members. You can respond to either of both of the questions. Is privatisation inevitable? How are we dealing with specialisation? James, you look poised to respond.
Poised. Is this on?
It is.
Excellent. No, I don't think privatisation is inevitable, and I think we should fight for the NHS because it is worth fighting for. I also don't think that there's a conspiracy. I really don't believe that there is a conspiracy in any political party. I think we've talked about a whole host of issues that we need to address, and we need to radically rethink what we mean, as we talked about today, what we mean by the NHS, what we mean by care, what we mean about whose responsibility is it, and just answering the question that came from the top, again, we have made our services, our systems far too complicated, and we can simplify them and we can make them much more person and community-centred, and that's the real opportunity that we should go for. And I think there's lots of ideas around. There's lots of innovation. I do worry about the next year, 18 months as we run up towards an election. It's never a great time for the NHS. But I'm hopeful that once we get over that, then we can build some momentum to do something different.
We're in our last few minutes. I'm sure there are other things that our panel members could add to this, but I'm going to ask our panel members to close with a single sentence of what your hope would be for the NHS in the next 75 years. So 75 years on, what will we be saying about the NHS? I'm going to start, Guy, with you.
I think we have, I don't think we can go far wrong if we go back to 1946 and what Aneurin Bevan managed to achieve and the things he said when the NHS was set up. And I think keeping the NHS public is absolutely vital to that. I do, however, think that we place too much investment in the wrong places. And we do need to shift a greater proportion to the generalists that are sitting out there in the community, often called general practitioners, but also the army of other professionals working alongside us in the community. And that actually we should also be investing in grassroots community organisations to support people's health and well-being in ways that we have not yet been able to successfully do. And I think if we can do more of that, keeping it absolutely publicly funded by taxation, grown in the way that Clare talked about right at the beginning to incorporate the social care aspects, then I think we'll be all right.
I'm going to go to our other panels. I'm going to be very strict. Just one sentence. Benjamin.
Lots of comments.
Okay, Benjamin.
Thank you so much. To me, I think NHS still have a future. Because although there are like so many issues we're discussing about here, but if we go to other countries, other continents, we will see that NHS in England, people might not agree with me, is still the best and one of the best service in the world.
That's a good sentence. That's a good sentence. I'm going to stop you there. We've got time. That's a good sentence to end on. James.
Still here, free at the point of delivery.
Excellent. Thank you very much. And Clare, final word from you.
Okay, I do think we're at a potential turning point, which I think the second questioner was getting at. And I would love to echo the positivity, but I think we do have to be wary and that we are at a potential turning point. If we look at some of the trade agreements that are being negotiated, NHS services are part of that. They're a huge part of the Brexit project in terms of thinking about what can we sell and what can we trade. There are big comments that everything's on the table and then, oh, actually NHS isn't on the table. But if we look in the detail, there are question marks about that. So what I hope is, yes, we still have an NHS. I hope we still have universal healthcare. I hope it doesn't become a poor service for poor people. But we are at that pressure turning point, and COVID, unfortunately, has kind of acted as a catalyst for that, and people are turning away a bit. And once we lose the middle class from the NHS, then it will become something for some people, but not for the other people. So there are worries. But yes, I do want it to be there. I want it to be there for my children and my grandchildren, and we need to make sure that it is.
Thank you very much. I'm afraid that's all we have time for this evening. I think a really interesting debate at a really interesting time for the NHS. Please join me in thanking our panel today, Professor Clare Bambra, Dr. Guy Pilkington, Dr. Benjamin Ajibade, and James Duncan. We hope you will join us. I know everyone's having to scoot off. We will be having future Newcastle debates. So if you'd like to receive our information, please subscribe to our mailing list. And thank you to the audience for your questions and your attention and for joining us tonight. I hope you have a lovely evening and we'll see you again soon. Thank you.